scar. Yes, can you play it, please?
So good evening, everyone.
Perfect.
And thank you, Team WIROC 2022. I'm going to take you all through the technique for total shoulder replacement and the way I do it to ensure you get consistent outcomes. So we had a 64-year-old male, right hand dominant, who came to us with significant shoulder pain dysfunction since a year. Now he was operated 40 years ago for a putty plat surgery for recurrent shoulder instability. He had significant night pains and could not dress himself as well. Look at the x-rays here. So he had a staple put into the glenoid rim with capsulorrhaphy, and as you can see, the joint space is destroyed with eburnated bone. The CT here shows that the head has subluxed partially posteriorly with flattening, and here the glenoid edge is reasonably well preserved with the staple embedded inside. Again, on the glenoid side here, it's reasonably concave and the head is deformed and point loading. We did a pre-op ultrasound to see the status of the cuff, which showed that it was bulky, but essentially the cuff was intact and there was mild fluid. We also did an EMG as he had significant deltoid wasting to rule out neuropathy, and that was normal. Look at his pre-op range. So he had flexion about 90, abduction 90, but a very tight internal rotation contracture of almost -20 and could not externally rotate. So this was the scar. The previous surgeon had used a large incision all the way from the top to the bottom. So the 3D CT here shows again the head with osteophyte built up both sides and the staple in situ. Now I do this in the beach chair position. A few important pointers. You need to make sure that you can get the arm absolutely perpendicular to the floor with full range of motion, and you have access front and back when you are doing complicated cases. Also make sure that you can see the C-arm images clearly. Now here you can see that even under GA, he has a very tight internal rotation contracture and just does not come out. So essentially the good old putty plat would act as a tight tether and push the head out posteriorly, and therefore this surgery went into disrepute. Majority of the papers would show that at 20 years, 60 to 70% of the putty plat operated patients would develop secondary osteoarthritis. However, this has lasted for 40 years. So I used the same incision, anterior deltopectoral, use part of the old incision and prolong it towards the pectoralis major. You go down in the deltopectoral interval, gently retracting the tissues till you come to the front where you can see the subscapularis and the capsule. So our first point of call was to check the cuff. So you can see here the cuff is reasonably well preserved, and although the ultrasound showed that it was hypertrophied and bulky, it seemed pretty normal on table. The next point was to extract the staple which was lodged all the way on the medial aspect. So after confirming cuff integrity, we went in looking medially to identify the glenoid staple, and there you can see we managed to pull this out, and with a mixed forceps I'm gently prying it out so that the staple comes out totally, and there we are. Once the staple is off, you then dislocate the shoulder. So with gentle flexion, external rotation, keeping the elbow at 90 and using levers on both sides, you make sure don't create a fracture and you get the head out. Once the head has been seen, you then try to find the center where you're going to ream into the humeral canal. So look at the biceps tendon and that will be your guide. The head is flattened and deformed. You go right down the middle and ream the humeral canal. Once that is done, you fix the jig onto the proximal humerus and do a very conservative cut. So when you're resecting in total shoulders, often you have to cut very little of the head, unlike what you're doing when you're doing a total hip replacement. You can always cut more, so be conservative with your first cut. Once that has been done, you will then nibble off all the peripheral osteophytes to make sure there is no obstruction to your soft tissues. Once you're reasonably happy with the smoothness of the cut, you focus on the glenoid, since you'll have a good view now, and you do a periglenoid soft tissue release. Be careful at the 6 o'clock position that you don't damage the axillary nerve. So release the tissues all round, and you can also use the cautery followed by a periosteal elevator to free the tissues. This will also help in the end to free up the subscap to give you a good supple closure. Give it a nice wash and make sure you can see the glenoid like the face of a clock. So see the superior, anterior, inferior and the posterior margin, and place your retractors on all sides to get a very good exposure. If you can't see the glenoid well, you'll be struggling with the glenoid preparation. So glenoid exposure is very important. You then put the central guide wire. Now every system has its pros and cons, but you put in the central guide wire and you ream the glenoid surface to make sure you just decorticate the eburnated bone. You don't need to really ream thoroughly because the base plate does give you some stability and you don't want that to be eroded away. Once you've done that, you drill with the central peg to find the midpoint of the glenoid, and with that you can then put your 3 peg drill bits to make sure you can get 3 holes nicely centered within the glenoid. Use a small curette to freshen the edges, and that's the trial glenoid which is pegged. So you've got the keel and the pegged ones. The pegged ones are superior. Put in your trial glenoid and see for the fit. You want to make sure that it's sitting smoothly all along the glenoid. You don't have too much of an overhang, and when you push it with your finger, you should get reasonable stability and it should not be rocking or feeling very loose. This is important because when you're cementing in, all you'll have is the 3 peg holes into which you're going to push in the cement. Once you've done that, nicely prepare, give it a wash, and there you can see the cement going in. I use a 20 gram packet of Palacos Genta. You can push the cement into the holes and with a curette remove all the excessive cement which balloons out. You want to make sure there are no peripheral fights behind, because that will cause again a tether and will create a tight subscap closure. So with a pressurizer, hold gently and make sure while the cement is setting, you don't move or you don't rock the glenoid. Using your finger or with a thin curette, all the excessive cement which extrudes out can be cleared. Be rock steady while the cementation is taking place. Now, once that is done and you're happy with the cement fit, you have to ensure post-cementing that the whole scapula is moving with the glenoid once the cementation is complete. Now here you can see that I'm placing the jig into the humeral canal, and this is like a calca reamer which reams the medial aspect so that the humeral stem sits flush with the proximal part of the humeral. So the trial stem has gone in, you put in a trial head, and now you see your reduction. You want to make sure that when you externally rotate to 30 to 40 degrees, the head is not dislocating in the front, nor is it dislocating with flexion and internal rotation out at the back. Also, when I'm closing the soft tissues which I've taken earlier on an ethibond suture, I want to make sure that at 30 degrees we're getting a nice closure and it's not very tight. Once you're happy with the version and you're happy with your soft tissue tension, you then decide to open the true implant, and here I'm using an uncemented stem. So the uncemented stem is now being tapped into the humeral shaft. So don't go hammer and tongs, go very gently, tapping 2 or 3 taps at a time to make sure you don't develop a peri-implant fracture, and watch the calca area very closely. Once you're happy with the stem seatage, you then use the head and place it. So with all systems you've got centric and the eccentric heads. Here I'm just using a box standard centric head on the stem because I'm very happy with the glenoid placement, and we're getting good coverage on the proximal humerus as well. So we're putting in the head onto the uncemented stem, and once we are happy, we finally tap it in so that the Morse taper locks. Now, once that's done, pull it out and see that it's not uncoupling. Very often, if you don't get this right, with your hand, the whole head can come out. Once you're happy, then relocate it into the glenohumeral joint and again do a test through the full range of motion. So with the arm by the side, with the arm up in the front, on the side, go through the full range and make sure that you're not dislocating either in the front or in the back, and make sure that you're not subluxating inferiorly. This again, you've tried it earlier at the trial stage, so you have to be absolutely happy before you put in the final implants, because once you put this in and if you're not happy with the reduction or with the stability, you can only play around with the head and the neck length. So here you can see the closure now with the ethicon sutures at 30 to 40 degrees. I reapproximate the soft tissues and make sure that the range is free and that the head is not subluxating. So I check it on table. Since this was a complex surgery, do a C-arm picture pre-op and then do an X-ray post-op to make sure that you're happy with the overall placement. This gentleman, we called him recently, 1 year follow-up, very happy, very pain-free. You can see the scar which has healed well, and you can see the static photographs showing his range of motion. And we also requested him to allow a small video shoot of his post-operative range. So he's got good function. His rotational contractures have disappeared. His activities of daily living have improved. He is pain-free. And as you can see here, he has achieved very good forward flexion and abduction.